Good morning, everyone, and welcome to our AIHI webinar today. We'll just give it another few seconds for people to join and then we'll start. Right, good morning, everyone. Welcome to our AIHI webinar, the Australian Institute of Health Innovation. We're very pleased to bring you our webinar series. To start with, I'd like to make an acknowledgement to country. I would like to acknowledge the traditional custodians of the land on which we are gathered and pay my respects to the elders, both past and present. I would like to extend that respect to all Aboriginal and Torres Strait Islander people with us today. Now I'd like to hand over to Professor Jeffrey Braithwaite, Founding Director of the Australian Institute of Health Innovation here at Macquarie University.
Thank you, Chrissy, and thank you for that acknowledgement to country and that warm welcome. So this is an AIHI seminar series special presentation by a colleague from Harvard, Dr. Ishani Ganguli. And Ishani, I'll say a few words just by way of introduction, but thank you very much. We know it's later in the evening on the east side of the US. So thank you for giving up your time and sharing your knowledge with us. We're very interested in this idea of low value care cascades. And I think you got lots of us in just with the title, let alone with your bio. So let me say a few words by way of framing your talk. So the Institute does a lot of research in your area, Ishani. So we're very interested in strengthening health systems through our research. We do research all the way through from policy, how does that work, through to leadership and management of health systems, not just in Australia, but internationally. And we're very keen on how does care get strengthened on the front lines so that we deliver better care to patients. Our logo, our mission, if you like, is heal, learn, discover, and we really love those three words. We spend most of our time in the Institute as researchers in discovery, but our object is to heal and learn and work with our stakeholders to heal and learn. The Institute itself constitutes a number of research centres. There's a couple up 100 of us in total. And this is just to give a flavour to the audience of the kind of research we do. And lots of the research we do is captured in the titles of our research centres. And there's three of us who co-lead the Institute. I'm the director of the Institute, run one of the centres, and co-lead with Enrico Coira and Joanna Westbrook the Institute itself. We also have a National Health and Medical Research Council. That's like an NIH funded partnership centre in health system sustainability. And this is a large national footprint across Australia of work we're doing to try and underpin our health system and make it built to last, more sustainable. And why I pick out that particular research grant that we've got, that particular collaboration, is that we are doing three things in that partnership centre. And the one in the very middle is looking at reducing waste and low value care. So we come to you as, I guess, an informed audience, not informed on your area of expertise, but already primed for a talk such as yours. And we're thinking too, how do we reduce waste and produce more low and less low value care and produce more high value care in health systems? So audience, Ishani Ganguli is Assistant Professor of Medicine at Brigham and Women's Hospital in the US. She came to us via a joint colleague, Professor David Bates, who's a long-standing colleague of the Institute's, and her bio is very impressive. I took the liberty, Ishani, of going to Google Scholar because many in the audience are researchers and they too are obsessed with their Google Scholar. Not that you're obsessed with your Google Scholar entry, but I took the liberty of doing that. And then we noticed how productive you are. This is your publications in 2021 in a number of, especially US prestigious journals, and you're in a productive phase in your career. And I think you'll find many in the audience also resonate with that, are in productive phases in their career. So there's a warm welcome from some of the people in the Institute. Thank you for joining us. Over to you.
Thank you so much for that warm welcome. Can everyone hear me? Sounds good. So I'm going to go ahead and share my screen, make sure that this is working okay. So far, so good. Excellent. So I really appreciate you having me. I wish I could be there in person, but this is a close second. I will start my talk with a story. So on a Friday afternoon, a few years back, I got a page from the preoperative testing clinic at my hospital. My 80-year-old patient, Lily, had gotten an electrocardiogram just to be safe before an upcoming low-risk office procedure. The EKG was a little off, the page informed me, but Lily felt completely fine. No chest pain, no trouble breathing, and she had no history of heart problems. But now that the result was out there, the procedure would be on hold until we had answers. Switch screens. Flash forward one borderline troponin result, several phone calls with Lily and with the anesthesia team, 14 emails, one visit, one cardiology e-consult, and a completely normal stress test. Lily was in no better health and was frustrated about going through all this trouble. Meanwhile, I felt helpless to change the course of events, and this was a relatively good outcome. We've all seen this pattern, whether as clinicians or as patients, a so-called cascade of further calls, visits, tests, and treatments. Each one a seemingly logical, even inevitable progression from the one before, full of sound and fury and often signifying nothing. In a sense, I'm just describing the practice of medicine, but the key point here is that these cascades can cause more harm than good, especially when they arise from an unnecessary test or unexpected finding, and when they're driven by the desire to avoid even the slightest risk of missing a potentially life-threatening condition. So we have good evidence on the extent and cost of these unnecessary or low-value tests, services for which the potential for cost and other harm exceeds potential for benefit. And it sounds like this is something that your institute focuses on as well. By US estimates, low-value care costs up to $101 billion per year. In contrast, the literature on cascades is sparse, although growing. There are several papers that describe the phenomenon with an impressive array of metaphors. My team has used the word cascade based on a pretty older, much older paper, a 1986 paper by Moldenstein that borrowed the term from clotting cascades from the biochemical pathway and was later used by Deo et al. To describe cascades that came from medical technology. I'm also partial to the Ulysses metaphor. If you remember from high school or grade school literature class, he was the Greek hero who traveled around the world only to end up right where he started. And you can see he's pretty upset about that too. There's been qualitative work capturing the effect of cascades on clinicians and patients. This is a nice study from the University of Pennsylvania in which a primary care physician described the distressing quagmire of follow-up for incidental findings as chasing a ghost. She says, I admit that most times, I think almost all the times, I will then get the follow-up study, although I sometimes wonder how much we are chasing a ghost that is expensive, but not necessarily going to lead to better outcomes. And on the right here, you see a framework by Deborah Kornstein and colleagues at Memorial Sloan Kettering in New York, which lays out the potential for patient harms from both low-value care itself, as well as the cascades that follow. And you can see there's a range from physical, psychological harms, treatment burden, social, and financial. It really covers the gamut. So there's more work to be done, though, to measure cascades, specifically to understand their drivers, their scope, and their impact. And this has been done to some extent in the cancer literature or cancer screening, but not more broadly as of just a number of years ago. And next, to design and test interventions to address these cascades as part of addressing low-value care. So in the rest of my talk today, I'll talk to you all about what my group and others have been doing to try to address these issues. So to start, our group surveyed a group of generalists across the US about incidental findings specifically in their cascades. So these were members of the American College of Physicians, which is our group of, is sort of our largest US society of physicians who are generalists. We looked specifically at internists and geriatricians, including trainees who were actively practicing outpatient medicine. We defined incidental findings as actionable or abnormal test results that were unrelated to why you ordered the test. And what we found first, when we presented clinical scenarios about likely benign incidental findings, it was really clear just how hard it was to leave one of these findings alone. So in one example I show here, we asked about finding a lung nodule in an otherwise healthy person. The radiology report said a follow-up was needed, according to the vignette, but guidelines were pretty clear that you should leave it alone. Nearly 60% in our survey still said they would do the testing or consult a specialist. And when we looked at potential predictors of testing or of taking that next step in the cascade, for example, age, experience, malpractice history, comfort with uncertainty, turned out that in this case, most of those factors didn't matter, and US trained docs compared to internationally trained, as well as less cost-conscious docs were the ones who were more likely to pursue that additional testing or specialist consultation. Then we asked about doctors' experiences with cascades from incidental findings. Not surprisingly, basically everyone had experienced it before, 99%, and I really do wonder about that remaining 1%. They had experienced them in some form, and the most common events were phone calls to patients. About 20% had these at least weekly, plus repeated tests and new non-invasive tests. Most doctors had experienced a cascade leading to an invasive test, an ED visit, or a hospitalization at least once. We also found that cascades that led to nothing, in other words, a dead end or a benign finding in the end, were more common than cascades that led to something clinically meaningful. And most doctors reported harms to themselves, like wasted time and effort, frustration and anxiety, as well as patient harms, and namely the ones that I mentioned before in the Dr. Korenstein's framework. Those are the ones we asked. And this happened at least several times a year that doctors noticed that their patients experienced this. We found that, these physician harms were most common among doctors working in rural areas. And this is likely due to fewer resources and sort of more frustration with wasting those resources or not having them, as well as doctors who said they felt uncomfortable with uncertainty. Then we asked doctors to think about their most recent cascade and to report it. And this Sankey diagram, which is a bit complicated, I'll walk us through it, describes the sample of cascades and the flow of how doctors essentially describe both those initial tests and what followed. So you can see here that the initial test was most often ordered by another generalist, less often the doctor themselves or a specialist, usually done in the outpatient setting, less often inpatient from the perspective of these PCPs. The most common type of test that initiated the cascade was an imaging test, less often a blood test versus other, most often done for diagnostic purposes as well as preventive. Most of the time, the test was considered clinically appropriate, but a third of the time it was not. And both tests that were clinically appropriate and not commonly led to some sort, or I guess had something intervenable, but also led to some sort of harm, whether that was physician or patient harm. Then we drilled deeper into why doctors pursued follow-up of the incidental findings. Nearly half told us the follow-up was not actually needed for clinical reasons, which is quite striking. So why did they carry through with the cascade? Many reported reasons like following community norms or the advice of another doctor. There were worries about being sued, which was already also quite common, especially for those who had been sued before. And less often, they said their patient asked for it. We also asked doctors about solutions, and this I've taken a step to translate this into Australian medical terms, but I think these are attendings are the GPs or senior docs, and the trainees are junior docs. And we see here that both groups ranked accessible evidence-based recommendations and guidelines highest, in other words, information they could access at point of care. And most also thought patient and clinician education would be effective in this case. Attendings or the GPs also favored malpractice reform, while trainees or junior docs were more bullish on value-based payment as a solution. Our team has also been using US national administrative and electronic health record data to quantify these cascades. And here I'll give a couple of examples. We started this work with a poster child for low-value care, which is preoperative EKGs for patients getting cataract surgery. And as you may all know, this surgery is quite fast. It takes about 10-20 minutes to perform. It's extremely low risk. And there's excellent evidence codified in multiple guidelines showing that routine testing before cataract surgery does not improve outcomes or lower the risk of adverse events in older adults, especially those without any sign of heart disease or any history. Yet, at least in the US, we do these tests quite often. By prior estimates, it was up to 1 in 4 cataract surgery patients received one. So we used national claims data from Medicare, which is the public insurance eligible to Americans when they turn 65. We focused on older adults with no heart disease who received cataract surgery, and we compared patients who got a pre-op EKGs to those who didn't, EKG to those who didn't, adjusting for patient, doctor, and area level confounders. And we use this to estimate rates of cascade events that might plausibly follow from that pre-op EKG in the next 90 days. And you can sort of see the scheme here of how we designed that. So what did we find? First, we found that 11% of our patients received a pre-op EKG, and this is based on a conservative estimate using diagnosis billing codes, and maybe an underestimate. These patients were older, they had more medical conditions, and they were more likely to live in urban areas and cardiologist-dense areas, and this is really consistent with prior literature on overuse in general. The cardiology-dense areas sort of refer to the phenomenon of supply-induced demand. We have more cardiologists and therefore more folks to refer to and more likely, higher likelihood of doing those additional services. Among all the pre-op EKG recipients, 16% had at least one potential cascade event. You can sort of see a flow chart here of how that played out. 1 in 8 had a cardiac specialist visit alone, while others had further evaluation of coronary artery disease, structural disease, arrhythmias, or more than one of these issues. For every 100 EKG recipients, we estimated 5 to 11 cascade attributable events. That's, in other words, additional events compared to the comparison group. And these really fell largely within the first couple weeks of this initial EKG, as you can see in this slide. And these services included tests and treatments like repeat EKGs, stress tests, echocardiograms, cardiac catheterizations, and new cardiac diagnoses. The additional cost per patient getting the pre-op EKG came up to nearly $600. And so if you put all of this together, we find that while most patients who got a pre-op EKG didn't experience a cascade, a substantial minority did, and the costs added up. If you do the math across the US, we estimate $35 million in cascade costs, which is 10 times that of the initial EKG. Then among pre-op EKG recipients, we also find that the ones who experienced a cascade were similarly older, had more chronic conditions, lived in more cardiologist-dense areas, or had the pre-op EKG performed by a cardiac specialist rather than a PCP. We've since expanded this work to look at cascades following other low-value tests. In this example, we know that annual checkups with routine testing are of limited use for healthy adults. And Medicare introduced the annual wellness visit, sort of their first version of an annual checkup in 2011 through our national legislation. And the visit doesn't cover routine testing, but doctors may still offer it, and these tests may cascade. So in a similar approach to the pre-op EKG study, we looked at AWV recipients receiving 3 routine tests and whether they were linked to cascades. So in this a healthy population without any clinical indication for any of these tests, we found that 19% received some routine tests during their annual wellness visit, which included 7% who got an EKG, 10% who got a urinalysis, and 9% who got a thyroid function test. These EKGs led to an additional 6 cascade events per 100 patients, sort of similar to our prior analyses for the cataract surgery EKGs. The urinalysis, an additional 5 events per 100 patients, and the thyroid test, no additional cascade events, although we suspect with longer follow-up and examination of drugs, we may have captured more. And the cost for these tests across all US AWV recipients was $34 million, and that included $9 million for the cascades themselves. Next, we've examined how a change in test and testing practice might affect cascade rates, with an eye more towards solutions or how you can sort of mitigate potentially negative effects of changing technology. So for context here, only about 5% of patients who come to the emergency department with chest pain are actually having a heart attack or acute myocardial infarction. Yet these patients commonly get troponin testing, that's a blood diagnosis test, to rule out this don't miss diagnosis. When the high sensitivity troponin test came out a few years back in the US, and it have been in other places like Europe and potentially Australia earlier, many worried that this new assay would pick up clinically unimportant elevations and lead to more cascades. So our large health system, which is called Mass General Brigham, introduced this new test on a single day in 2018, along with clinician education and new protocols, which gave us this chance to test the theory. So we used electronic health record and billing data across our 5 emergency departments to compare cascade rates among patient visits for chest pain before and after introduction of this new assay. And we used all other patient visits for any other condition or any other symptom as a comparison group. We used difference in differences analysis to estimate the net change in cascade rates among chest pain patients compared to those other patients while accounting for temporal trends. And this image here shows our overall results. We found that after introduction of the new assay, patients with chest pain had a net 3% higher chance of having some cascade event potentially related to getting a troponin. Specifically, they were more likely to have multiple troponin tests after that first one, or one or more EKGs. But when we drilled down into specific cascade events, we found that they received net fewer of some of the tests that we were more concerned about, or services. So they had net fewer stress tests, net fewer catheterizations, net fewer cardiology evaluations, and net fewer hospital admissions. And these were the more costly or invasive cascade events, which gave us some hope that the new assay may actually have a net benefit in streamlining the cascades. And the graph you see here focuses on the hospital admissions. You can see that for patients without chest pain, the rates of hospital admissions really stayed flat over the time period, but for those with chest pain, we saw quite a large decrease. And these are our results across the board and sort of iterates what I showed before. A net increase in any cascade event or troponin tests. You also notice a slight increase in new diagnoses, which may not be surprising given the greater sensitivity of the test. But really, there were fewer medications used, fewer use of cardiology services, and fewer hospital admissions and chest tests, as I mentioned before. So putting this all together, what we find in this work, that cascades often start with this low value or unnecessary test, sort of by definition, or an unexpected finding. And we find that drivers of cascades are in many cases similar to drivers of that initial event. So you see here, it's often practice norms or culture of medicine. At the individual level, it could be a doctor or patient's anxiety or intolerance of ambiguity, which is something that we all struggle with in medicine. There's fear of malpractice, which is a big issue, especially in the US, in certain states. There's the perception of patient complexity, which may drive more use of care, either at the outset or in subsequent cascades. And then there's supply-induced demand, the idea that if you have more services or financial incentives to order more care, then that's going to happen. So what we've also learned is that physicians frequently experience cascades. When you ask the doctors, they experience them quite frequently, and more often than not, these are cascades that are not leading to anything clinically important. We also find that tests vary in their cascade potential. So for any given test, a minority experience the cascade, but this still comes at a significant cost financially, as well as other harms, both to patients and clinicians. So what's next in this work? So we and others continue to use claims to quantify cascades that follow other low-value tests or incidental findings. There's a study done by, I believe, a gentleman who's in your group, Dr. Badgery Parker, measuring hospital-acquired complications after low-value procedures. We're also looking at other examples, for example, screening breast MRI among average-risk women and low-value imaging for low back pain to measure cascades following there. And then it's important to acknowledge that the claims-based methods that we've largely used have some limitations. So claims can't precisely reveal clinical intentions behind services, as one example. So another key step is to measure cascades using other data sources like the electronic health record or interviews with patients or surveys, and use other approaches to measure and create experiments around these services. So natural experiments to try to measure cascades, and then also just more detailed collection of cascade events in any kind of clinical trial, because they're outcomes that are often overlooked, I should say. And it will be important to measure patient experience of cascades. And this is something that I alluded to earlier. This is something we're starting to do through interviews. And then the next big question is interventions, right? So we can talk a lot about the extent of these cascades, but what do you actually do to reduce them? That's really the critical question. So again, knowing that cascades are common, that they come at these significant costs to patients, physicians, and society, what can we do about them? The first approach is to avoid low-value tests in the first place, and that's because it's easier to not know about an abnormality than to unknow it. And this is the work of the International Choosing Wisely campaign, which educates on tests and treatments that patients and doctors should question. We've found in work that's under review that the majority of Choosing Wisely recommendations do name low-value services with high potential for cascades. So that's an important intervention. Another approach is quality improvement within practitioner systems. And one example I cite here is a really impressive intervention by John Maffey and colleagues in California, in which they were able to reduce pre-op testing for cataract surgery patients using plan, do, study, act cycles, and by sharing data with anesthesiology and ophthalmology leaders in their system. The other approach is mitigating cascades once they've started. And this is in theory harder than avoiding low-value tests because it's driven less by habit and more by anxiety or fear of missing something. By definition, once you see that test abnormality or incidentalloma, that cascade feels impossible to stop. Cascades are also driven by positive feedback loops. And an incidental finding turned out to be cancer once, and you're relieved to have found it. And even the nothing cascades have a positive feedback loop. So at the end of our EKG saga that I mentioned at the beginning, both Lily and I felt at least a little relief that she showed no significant heart disease. So to mitigate cascades, we need to give both patients and doctors the information and the cover to do less instead of more. And this could mean point of care information, as the doctors in our survey alluded to, informed by high quality evidence rather than expert opinion alone, as well as shifts in culture or community norms and educational interventions. To this end, there's an interesting example that came out recently. This is based on the observation that spine imaging like X-rays and CT scans inevitably show degenerative changes that are clinically insignificant yet can lead to more tests and treatments. This was a multi-center US study that randomized patients getting spine imaging to receive either the regular radiology report or a report that explained how commonly any abnormalities would be among similarly aged people without back pain. Disappointingly, patients who got the enhanced reports had no fewer spine-related medical services in the following year overall. But I suspect the intervention had other benefits the study did not capture, like easing patients' anxiety about their test results. My group is working on a different approach. We set out to design initially an intervention to reduce cascades. And in the process of doing interviews with patients and doctors, we realized that cascades are really difficult for people to conceptualize before they happen or even sometimes after. So we went upstream, and the goal here turned out to be improving patients' medical test literacy and making it easier to talk about the limits and consequences of even so-called routine tests. Specifically, we designed a web-based intervention that teaches patients that tests aren't definitive, for example, that they can have false positives and negatives, they can show incidental findings or abnormal but unimportant findings, that they can cascade. And these are insights that we found from these interviews patients did not have, although I do suspect that with COVID testing and that sort of discussion around that, there has been more literacy and understanding overall. We also designed references for doctors to have better conversations, and we're planning to deliver these references along with individualized data on how often these doctors order low-value tests compared to their peers. So there's a bit of a peer comparison nudge component as well as references on the physician side. And we're now in the process of recruiting doctors and patients to test this intervention in a randomized controlled trial. We're deep in the middle of that right now. So putting it all together, I guess a few takeaways. We know that cascades are common, especially those following low-value tests or incidental findings, and that they carry substantial financial and non-financial costs, both to clinicians and patients. And this is really maybe aimed at the clinicians in the room, thinking ahead to the next time you face a potential cascade, and chances are it'll be soon. I'll humbly submit a few somewhat evidence-based suggestions. One is to think twice or read or talk to colleagues about whether you really do need to chase that ghost, and oftentimes it's not the case, even though we feel compelled. Another is to talk to your patient about the potential harms and potential benefits of the service and cascades early on, and not to assume that the patient just wants the test. What's clear from our research and others is that doctors often overestimate the extent to which patients ask for more testing. And it's really on us as clinicians to frame a benign cyst as benign and to frame the options in a reasonable way to our patients. And finally, always important to consider alternatives, including active watchful waiting, which if framed appropriately can be a reasonable and really appealing option to patients and for us as well. So I want to thank you so much for your time. I have a long list of collaborators on these various projects that I'm deeply indebted to, and our funders as well. And I couldn't resist but including a photo of my older daughter, or my older child, who's my daughter, who this week was doing a project on Australia, and this is her creating her sketch with her in her classroom mask. So I will pause now and take questions, comments. I'll end on this slide because there's some more takeaways here. And I'll hand it back to you, Jeff. Thank you.
Thank you, Ishani. That was fantastic. And you managed to cram, without rushing, cram an awful lot of knowledge into a great talk. That was really good. Maybe you could stop sharing the screen.
Yes. Okay.
And then we've got some questions coming in on chat. And also, I think we'll provoke a bit of a healthy discussion here. So firstly, thank you very much indeed. That was a lot of your work, I know, but not all of your work. We had a look at your profile and all the other things you're doing and publishing on. But that was a really, I think Cascades is a very powerful tool for thinking through, I guess, low value care. Yeah. And things that we might do that we don't want to do. We've got some comments coming in. Chrissy, are you cool for me to moderate these? George Mark Jealous, who's a very good colleague of ours, long-standing colleague of ours, interested in aged care. A couple of questions coming in. One of them, I'm just going to touch on the. He's written a whole paragraph. I'm just going to touch on. We're having a royal commission. We've had a royal commission into aged care in Australia, and there's been some concern about how we handle aged care in residential aged care facilities. There's a problem coming down the line, George says, so we'll do a major transformation of our aged care sector. And that may mean a whole lot more testing and diagnosis of incidentalomas in that population, a population that often we don't really want to treat much, let over-treat. So have you got any suggestions for us as we go through this country-wide change in the way we handle aged care, because we have had a big inquiry and a big commission that's going to force change on the system?
Mm-hmm.
And perhaps what role decision tools for providers and consumers can make through this transformation at the level of the whole country.
Yeah, I guess I'm curious to learn more about what that transformation looks like, because I think that thoughtful attention to the value of care and avoiding the low value care could be part of the transformation rather than a consequence, rather than an unintended consequence. So one example that I think of in policy in the US is, I mentioned the annual wellness visits, and that there was some low value care that was occurring during them. But I think the way that the policy was designed was to focus those visits on what the aging population needed. So for example, focusing on depression screening, on screening for frailty, screening for cognitive decline, and there's no mention whatsoever of lab testing during those visits. And so any testing that was done was really incidental to the visit and the policy. And so I guess there's two pieces. One is, will there be any increase in testing is it sort of the intention of these transformations, or do you worry that because there is going to be more care offered to these older adults, that sort of unintentionally you will have more exposure to doctors who want to do the tests? And those two different things.
Yeah. Yeah. I mean, I think a lot we don't know, and right. A consequences to the changes that are mooted are going to come down the pipeline. Can I shift pace a little? And we published a paper with an intensivist colleague of ours a few years ago, Ken Hillman. He's an intensive care specialist, and he cut his teeth on medical emergency teams, rapid response systems. But the idea he was having when he was sitting in his intensive care unit was, there's a whole lot of people who come here and no one votes as to how they get there. So there's someone in the community right now, something happens to them, they go to a general practitioner or an emergency department. It's almost like the patient cascades. You've been looking at tests and providers and patients, but this is the patient cascading through the system. No one person is in charge. They end up in his intensive care unit. A third of patients die in ICU in Australia, and probably that's an international figure. And no one voted, no one was in charge. So it made me, I was hearing you, who's going to arrest this? there's no one person in charge.
Yeah, I think the ICU is one of the more dramatic culminations of a cascade. So I think that fits very well with this framework. And I think the point that you bring up is so central to this idea that each individual decision seems logical, right? And nobody would fault you for making that choice given the choice before. But when you take a step back and in the absence of somebody being in charge, as you say, or one sort of quarterback or person who's seeing the big picture, it's very easy to go down that cascade and that patient ends up in the ICU when perhaps that wasn't what their goals of care were. And that's particularly really problematic when these are older adults or folks who, anybody who didn't want that kind of outcome, or when the likelihood of a good outcome clinically is low.
Yeah. Now that's very interesting. George asks another question, George Margellis. George is one of the most thoughtful people that we have in our stakeholder group. And he says something extraordinarily interesting that you called supplier-induced demand, which is often the elephant in the room. Mm-hmm. He says one person's waste is another person's revenue. Often low-value care is bread and butter revenue for a provider, which complements the low margin, high value care that otherwise they would produce. So it's a kind of economic and a hard place situation. You must have thought through that too, and you alluded to it a bit in your talk. Any observations for us?
Yeah, I mean, I think this is part of the challenge. So I think one example, or I guess one case study I would share is thinking about choosing wisely. And this is work that, again, is sort of in the publication is not yet accepted. So I will speak a little bit obtusely about it, but it's what you find is that the choosing wisely, as you know, physician societies were asked to name low value services. And oftentimes what we had found in early examinations of what these lists included was they didn't tend to include services that would affect the revenue of members of that physician society, right? So, the general, I'll pick on my own group, general internists were mentioning radiology scans, for example, that wouldn't affect their bottom line. And we see that in an analysis of at least US choosing wisely to date, that continues to be the case, that most of these services are not affecting your own revenue for sort of obvious reasons. And that sort of points to why it's hard to only rely on physician societies to police themselves or to reduce low value care without external stakeholders playing a role. And it's absolutely true, right? So any, you think about administrative waste in healthcare, we talk about that a lot in the US. Those are people's jobs, right? So when you're talking about job numbers on one hand and reducing administrative waste, you're messing with those job numbers. So it is really a give and take. And I recognize that all of these are not without their trade-offs. And I will also just to try to not to point fingers, I think that, I myself am a victim of supply-induced demand, right? So we have e-consults in our health system. So, and I don't know if that term is used more widely, but it's essentially I can do a virtual consult with a specialist. And because it's easily available and it doesn't cost me anything, I have a lower threshold now to ask a question where maybe before I would have done some more work looking something up. And that's a classic example, but I'm for sure privy to that as well. Yeah,
no, that is a very good example. The economists were right. There are consequences from incentives, and they change behaviour. Another question coming in from Caroline Brand, another colleague, long-standing colleague of the Institute. A reasonable number of people, was it around 36%, are concerned about being sued in your Do we have access to data about numbers of cases arising each year from failure to follow up incidental abnormal tests? Maybe evidence of low adverse legal outcomes could be used for educational purposes.
Yes, it's a great point. I've actually had the chance to at a unrelated dinner, was sitting across from the medical officer of our medical insurer for our health system and struck up a conversation about Cascades. And what I learned from him, which was not too reassuring, was that the biggest source of malpractice lawsuits within our system, but I think more broadly, is misdiagnoses. So it's exactly what doctors stay up at night worrying about. But I think that, that's the denominator there is all types of malpractice cases. But I think the question that's raised here, which is a great one, is that how often, or for how many patients or how many imaging tests, for example, is there a lawsuit? And those numbers are going to be really small. And so, yes, I think that's a really wonderful point. And that goes to the idea of giving doctors cover to do the right thing, making doctors feel like they can pursue that path without taking that huge risk.
Okay, that's very useful. This is, and incidentally, I know we talked offline before the seminar. This is very useful in an Australian context, and all the terminology you're using is very, very similar. Sure, we might call junior doctors, but the rest is absolutely riveting for us. Martin Henscher, another colleague of ours, is saying an interesting question. This is a change of pace. Are you seeing any generational differences in physician attitudes to, different culture, I guess, risk, ambiguity, tolerance, willingness to do another test? Are we expecting a cascade across the generations to use, and a change in the way people do medicine?
Yeah, it's a good question. So in our study, which is maybe a sample size issue, we didn't see significant differences by age, but the effect estimates would suggest that there is some. So I think younger docs who are fresh out of training tend to be a little bit more risk averse, or in other words, doing more of the tests. And there is some greater tolerance for ambiguity in docs who are more experienced, which makes some sense. The other generational difference, and I think I mentioned this briefly in the talk, is about thinking about solutions and what doctors would believe would help mitigate cascades. And one that really struck me was that that junior docs are not really subject to malpractice, and that's not something that they think about day in and day out. And so for them, that wasn't wasn't high on their list. Whereas they were thinking more about value-based payment. And I think the reason for that is not because they have experienced it themselves, because I can tell you residents don't actually are not subject to those financial incentives. I think it's because that concept of value-based payment has really infused discussions in that generation. So we now understand that to be sort of a better way of practicing, and there's sort of moving away from fee-for-service. I think that is another generational difference. Now, the separate question of whether value-based payment will actually make a dent in low-value care is a separate one that I am very pessimistic about, because I think that there's so many competing priorities or demands. But those are some examples of generational differences.
Yeah. And there's a later breaking question from Anne Carrigan, who's a psychologist who works with us as a researcher. And she says a similar question to that one, to Martin's question, but also says, do you think there are any individual differences such as personality at the provider level? Now, that's not in your data, I doubt, but it's an interesting, pondering sort of question.
Yeah, so we do measure, we use some existing validated instruments to measure aspects of what you could call personality. So we looked at cost consciousness, and we also looked at discomfort with ambiguity or uncertainty. And found some small effect sizes, but found some correlation between being less cost conscious and doing, so docs who were less cost conscious did more cascades, at least in the clinical vignettes. And then the doctors who are uncomfortable with uncertainty were also more uncomfortable with cascades, which sort of makes some sense. There is other work, some down the pike from some colleagues looking at other, using surveys to look at other correlates of low value ordering in general. And I think that is, anecdotally, clinically, you see that, right? You see some docs who are just inclined to do more and others who are more comfortable. And we have some ways of capturing that through surveys, but they're not perfect. So I think there is room to do more with that.
Okay, I'm just going to say to the audience, have your questions coming in, because we're entering the last few minutes, the last 10 minutes or so. We don't want to keep you after hours, Ishani, because it's already after hours for you. So couple of other things people are saying. One is from Catherine. How do we factor in, this is more on the patient side now, how do we factor in patients' values and choices? In other words, patient-centered care and patient autonomy is quite difficult in the era of 6-minute medicine where, especially in general practice, you know, there's high volume, short consultations. And so time isn't really available to talk to patients. Therefore, we're not eliciting what matters to them from a short conversation. So that becomes kind of difficult from a Cascade perspective. Questions, please?
Yes, great question. I think that one of the solutions is exactly that, to make space for those conversations. And that's where the intervention I described is hoping to make a difference, right? Is to give patients and doctors the tools to talk about this, hopefully eventually in a quick way, but nonetheless to have for patients to have the knowledge going into the visit about what medical tests can and cannot do. We're hoping that that information going in can prime patients to ask questions when it's appropriate, or when there are important questions to have, and then prime doctors, meanwhile, to bring this up and to engage in shared decision making. I think that you know, you probably all are familiar with it, the wide body of research on shared decision making and the importance of for decisions that have clinical equipoise. And generally, these are used for big decisions that patients and doctors work together to figure out the right step that's aligned with patient preferences. Part of the goal for this trial that we're running is to lower the bar, in a sense, to try to make shared decision-making part of everyday practice at in a more micro sense. So for any medical test, making sure that the patient understands why they're doing it, what are the alternatives, and you know, what are the potential consequences, including cascades. And we hope that that gets to that towards that goal of patient-centered care. But a barrier, and this is something we asked doctors in the trial, and I'm interested to see the results, is time. And we worry about that being a big one.
Yeah, I can see that. Got another one coming in from Anne Carrigan. I'm not sure if this is a question or a statement. I know Anne is very interested in imaging, as well as being a psychologist. It would be interesting if there are less cascades post-breast MRI compared with mammography, given that MRI is the gold standard. Not sure if that's...
So we have preliminary results there, finding a lot more cascades with MRI.
Yeah.
And just as a preview to that, what's interesting about that particular study is that MRI, unlike other forms of breast imaging, MRI shows extramammary findings, or it has the potential to. And so therefore, any findings that are outside of the breast are only going to be found in MRI, but not in other imaging tests. So if you difference out those estimates using some of the approaches we've used before, you see quite stark differences. TBD.
So I think we're reaching the end of the questions. I've got one for you, I guess. So a couple to finish with. One is, so next studies, where shall we look? You gave us a taster of that in your last couple of slides. Where shall we look? What can we expect next in this area? And also broadening it out, we know you're interested from your profile in a number of other things. What else should we look when we're searching Ganguli and looking for more from you?
Well, thank you. I appreciate that.
What other things are you interested in?
Yeah, so one paper, and this came out a couple hours ago, so I would love to mention it, is just measuring low-value care across health systems and thinking about health systems as an important source or locus of control for low-value services. And in the US, at least, and I think this is true across the world, more and more patients are going to health systems. There's more consolidation. Patients are going to health systems for their care. So we measure low-value care at individual systems. And one thing that's special about this work is that we actually name the systems. We're saying, we're ranking these systems based on how much low-value care they're using across 41 measures. And the goal there is to start a conversation, to start these systems thinking about their particular profile of low-value care use. Maybe they're the ones doing more PSA testing, but less of another service, and using that to look internally and to use some of the levers that health systems have. For example, peer comparison as we're doing, or clinical decision support in electronic health records, or even using low-value care use in hiring decisions or retention decisions to influence those measures. And on the flip side, we hope that patients can use this to be informed as they go to a health system or decide where to get care. So that's one example. I think in the Cascade space, I think some of our work, as I mentioned, is looking at other services that may cascade and doing some more measurement there. I'm still on the lookout for other ways, more clever ways to measure this, short of an RCT, and how often these are happening. And then solutions, again, are really critical. I think it's easy to keep measuring things, but unless you're trying to intervene on them, it's not as useful. And so thinking about other, I think the behavioral economics lens is really interesting to me. So how can we use that to try to intervene? Thinking about how radiology reports may be useful, or like better radiology reports are enhanced, or ones that have maybe even customized patient or customized guidelines based on different patient phenotypes. There's a lot of creativity there, and thinking about other ways of presenting the information that may reduce cascades. And then broadly speaking, my other work, as you saw, Jeff, is thinking about payment and delivery of care, especially primary care, how people are using primary care in the US, which is to say less and less over time, and what we can do about that, because that's really problematic. And some work on gender equity too. So those are all my passion areas.
We would certainly like for some of those additional areas for you to come back one time and give us a talk on some of those other passions and interests of yours, because a lot of what you said just then resonates with many people in the Institute and in our audience. So final question, I guess, from me, which is, I guess, different health, you were describing health systems, I guess, within the US context, different, whether it be a provider in a couple of states over there, or a couple of states here, or the ones in Boston. But there's also the notion of national health systems are different from the US's. The US is often an outlier in terms of a health system. It has idiosyncrasies not shared by many of the other health systems in the world, many of which are largely publicly funded with a bit of a private sector compared to the US. So how generalizable do you think the cascade is, and where do the different structures in the system and the different ways the system is built and the different incentives push or pull cascades in different directions? I know that's a question without notice and unfair, because there's 190 countries in the world, but do you have general observations on that for us? Yeah,
it's such a good question. I think that, in fact, I was reflecting on this before giving this talk, trying to think of the Australian context, and I realized that cascades are universal. I mean, this is human medical nature. We're going to find, we all have excellent technology, like imaging and other technology. We're going to find things that we shouldn't have found, and we're going to want to follow them up. So I think the financial incentives are part of the story, and there are financial incentives in all countries. And I think the health, there are many ways in which our health system is embarrassing and problematic in unique ways that aren't translatable. But I do think that low value care, I'm learning in this process, is just quite universal. And we're all struggling with a lot of the same things. I didn't criticize your health system, Ishani. I did. That's okay. I didn't say it was embarrassing. We've in fact, the world's learned a lot from the US health system. But yes, it does have idiosyncrasies that if you were building it from scratch, you may not perpetuate. Yeah. No, and we teach our students that history in order to not repeat it. Exactly. Well, listen, thank you very much. We know this is out of hours for you and it's evening time, and you've been very generous with sharing your wisdom and expertise and also your time. So on behalf of the Institute and all of our stakeholders who came to this session, we very much enjoyed it. Carolyn Brand signed off and said, thanks for the session, such an important issue. She's right. Thank you very much. It's a pleasure to talk with you. And yeah, if you do some international studies in this area, we'd certainly be happy to collaborate with you. That sounds wonderful. Thank you so much. So on behalf of everyone, thank you very much, Ishani. Thank you, Professor Ganguli. Thank you.